All right, so this is where we're going to really get into interpreting pulmonary function tests so that you can feel confident making an accurate assessment of what the respiratory condition is based off of what you're seeing with the spirometry. So again, we have our volume time curve and our flow volume curve, okay? We went over this in our first lecture together, but just walking through it because now I have gotten this example here where A is normal curve for both diagrams, B is obstructive, and C is restrictive. Okay, so we're going to walk through what this means. So first off, look at the shape, okay? So let's look at the normal shape. So we have, then again, this is for the spirometry for forced vital capacity. So the patient inhales as much as they can, and they exhale as long and as fast as they can. So the forced vital capacity reaches a plateau. 6 seconds of exhalation is necessary to make it a good test. And then forced expiratory volume in the first second is right here. In obstructive lung disease, such as asthma, there's obstruction to the air getting out. The air is not effectively getting out of the lungs because of the obstruction. After it gets through the initial obstruction, then eventually it kind of catches up to the forced vital capacity. But that FEV1 is low, less than 80% predicted in obstruction. And if we do the math, FEV1 right here, first second. Okay, we're about maybe 2.2. And FEV1 first second, almost 4. Okay, so that's obstruction. When we look at the flow volume curve, the flow rate is reduced, again, when you're exhaling forcefully against obstruction, asthma. The air isn't able to get out, and so it's a reduced peak expiratory flow. But the forced vital capacity is almost close to normal, okay? And basically, in obstructive lung disease, such as COPD, asthma, airway narrowing, the loss of elastic recoil leads to airway collapse and increased resistance in that first second. And after reaching the peak expiratory flow, the rate of airflow declines also more rapidly than in healthy lungs. And that also leads to this kind of scooped out appearance on the tail end. This descending limb of the expiratory flow volume curve reflects pathological reduction in airflow due to the obstruction, which disproportionately reduces the FEV1 compared to the FVC, resulting in a low FEV1 to FVC ratio. Just as a caveat, the FEV1 cannot be calculated from a flow volume curve. It can only be calculated from a volume time curve. So we're going to look at restriction now, okay? And we're going to contrast that with normal and obstructive. So C is restriction, okay? You'll see the FEV1, it's pretty close to the FEV1 on the normal, but it's the FVC that's significantly reduced compared to the normal. We see it again here, okay? Peak expiratory flow, we're almost at peak of normal. but that FVC, which is represented, and you can even see the FVC here on this horizontal axis is 5 and normal for A. It's 5 and normal for A on this loop too. So that matches up those volumes. Okay. This axis, this expiratory volume axis on the horizontal axis of a flow volume curve is the same as the vertical axis on a volume time curve. And that's why the FVC, that volume is the same. It's just in a different location. They're different curves, but that's why FVC, that's what this 5 represents, is the FVC, forced vital capacity in liters, 5 liters. Okay. So with the restriction, that forced vital capacity is reduced. It's only 3.75. 3.75 here, okay, for the forced vital capacity. And so a restrictive loop is both narrower and smaller. So this is narrower and smaller. It has a pretty steep descending expiratory descent. Restrictive lung disease is defined by a reduction in the total lung capacity, which limits the maximum amount of air that can be inhaled or exhaled. This results in the reduced forced vital capacity and the lower overall lung volume, causing the loop to be compressed along the volume axis. Even though the peak expiratory flow may be relatively preserved or even increased due to elastic recoil, the absolute flow rates are reduced because the available lung volume is diminished, leading to the lower maximal flow and steeper, more convex expiratory limb. So when you think of obstruction, think about reduced FEV1. When you think about restriction, think about reduced FVC. On the flow volume curve, when you think about obstruction, there's reduced peak expiratory flow. The air just doesn't gain out. Restriction may have a normal peak expiratory flow, but a reduced FVC. So you can get so much information from looking at these curves, and in addition to the numbers, the percentages that you get on the pulmonary function report. We went over this in our first lecture, but bronchodilator testing is needed if any of the percent predicted values are less than 80%, and a more than 10 to 12% or 200 milliliter increase in FEV1 or FVC after the bronchodilator indicates reversibility. Asthma is usually fully reversible, while COPD is not typically reversible. Diffusion capacity of a lung. This is a big one, okay, because it's very important to know if you need to order this as an ancillary test after you get your pulmonary function result. So we're going to go into this in detail. Diffusion capacity of the lung for carbon monoxide measures the ability of the lungs to transfer carbon monoxide gas from the alveolus to the capillary in the blood. Carbon monoxide is used to estimate gas transfer instead of oxygen because carbon monoxide has a much higher affinity for hemoglobin. DLCO test results are adjusted for the hemoglobin level, and they are also corrected for altitude because as the altitude increases above sea level, DLCO increases unless corrections are made because DLCO varies inversely with changes in alveolar oxygen pressure. This is not something that we typically do in our office. This is a send out test. So this is an image about the different scenarios of DLCO in different lung conditions. Reduced DLCO occurs if there's less surface area available for gas exchange. So less surface area would be an emphysema because of destruction of the alveolar walls. It also, reduced DLCO can happen if there's less volume of blood, like anemia, because there's less blood to bind to the carbon monoxide. DLCO should be normal in airway diseases that only affect small airways like the asthma or chronic bronchitis. A blood clot obviously would reduce the DLCO. Restrictive lung disease, where there's fibrosis, scarring, sarcoidosis, will decrease the DLCO. There's just not the exchange across the alveoli because of this scar tissue and inflammation. Again, an emphysema, because of the loss of the alveolar walls, the terminal lung units are so much larger, it causes the gas have to diffuse further to reach the alveolar capillary membrane. This is an image again showing DLCO in another way, and just thinking about the area available of tissue for alveolar capillary membrane, the thickness of the membrane, which would be increased in fibrosis, sarcoidosis, inflammatory lung conditions, the hemoglobin, the driving pressure. Decreased area for diffusion occurs if there's been lung resection, idiopathic pulmonary fibrosis. Increased thickness of the membrane for diffusion increases in congestive heart failure, pulmonary vascular disease, again, idiopathic pulmonary fibrosis. Carbon monoxide exposure or smoking can decrease driving pressure for carbon monoxide diffusion. And then hemoglobin being low, that can decrease the DLCO too. In asthma, the DLCO can be high because sometimes there's increased blood flow around the capillaries in the lung, alveolar capillary area. Obesity also can be associated with a higher DLCO value. And you'll see this table, this reference table here, and feel free to take a screenshot. What we're really looking at here, you know, again, if you have a patient, because I personally don't check a DLCO in people with asthma. Okay, I don't need a high DLCO to tell me asthma. I determine asthma from the fact that, you know, the FEV1 is low, and then there's reversibility after a bronchodilator. There's a 10 to 12% increase, or 200 milliliter increase in FEV1 after the administration of albuterol. That's what tells me there's asthma, okay? But say the lung PFT results show restriction, so a low FVC, and the patient's obese. Well, that DLCO is going to be important then, because if the DLCO is normal with a restrictive pattern of PFT results, then maybe perhaps it's the obesity, right? I also check a chest x-ray too if one hasn't been done. But if it's a reduced DLCO and there's a restrictive pattern on the PFT result, and maybe the chest x-ray shows things, maybe it doesn't, but then I'm worried about pulmonary fibrosis, okay? Sarcoidosis as well. I don't typically need a low DLCO to make a diagnosis of emphysema, because they'll typically show up on chest imaging, chest x-ray even. But DLCO is most helpful to order when you have a restrictive pattern on spirometry results, and especially also if the patient's obese. Sorting out a low DLCO with restriction on pulmonary function. That is very concerning. for a pulmonary parenchymal issue, something at the capillary alveolar interface that is preventing that carbon monoxide from effectively diffusing across that alveolus into the bloodstream. Okay, that's what we're worried about. Pulmonary fibrosis with a low FVC restrictive pattern. Chest x-ray, we're allowed to order it, and I do, because it looks for parenchymal lung disease. It's not as good as a high resolution CT chest, but it's something I have available to me. So I do it whenever possible. Also, if a veteran states that they were exposed to asbestos, it's very helpful to look for pleural plaques or pleural thickening. In emphysema, there's frequently flattened diaphragms, hyperinflation, bullae. So chest x-ray is something that's very easy to order, not as hard to get back as the DLCO. So we're going to go into a couple different patterns of what these look like on results. Obstruction, the most common is asthma, chronic obstructive pulmonary disease, emphysema. You'll see the overlap here. Okay, asthma overlapping with chronic bronchitis, with emphysema. And really the issue is the narrowing of the bronchioles. In COPD, there's destruction of the alveoli. Again, an obstructive pattern on spirometry is a low FEV1. FVC would be normal or decreased. These are the curves. And again, what we normally get is just that flow volume expiratory curve, okay? You'll see because of the obstruction, you're not reaching that peak expiratory flow. Forced vital capacity is slightly reduced, just similar to what the predicted would be. Asthma and emphysema are most common, but there's also these other extrathoracic or fixed obstructions we're going to go over. These are other ways of expressing the intrathoracic, extrathoracic, or fixed obstructions. And these make the most sense to me. So that's what I'm going to use as the example. These are all examples of large airway obstruction, by the way, versus asthma and emphysema are small airway obstructions. In a variable intrathoracic obstruction, the peak expiratory flow is reduced, and the inspiratory is pretty preserved compared to the expiratory. Again, we don't usually get the inspiration loop, inspiration curve. We only get the expiration curve. So we won't be making these diagnoses too often, but it's just helpful to know. And the reason why the expiration loop is so reduced in an intrathoracic obstruction. So here's the obstruction, okay? Intrathoracic. Is because when you inspire, that airway pressure, whatever is doing the obstruction, most common like a tumor, that pressure is pushing open the airway from inspiring. But when you're expiring, the pressure, when you're exhaling, these small airway pressures cannot compete against the area of obstruction. So again, like a lung cancer, including the trachea intrathoracically, or granulomatous granulomatosis was polyangiitis, formerly called Wegener granulomatosis. For variable extrathoracic, this would be like a goiter. It's outside the chest cavity, right? So it's wherever the blockage is closest to, this is the mouth, right? Where the air is inhaled. It's so much pressure for that to face when you're inspiring. So that's why the inspiration loop is truncated. But expiration, there's more way to get momentum to get the air out, if that makes sense. So wherever the blockage is, closer to that blockage, it's going to be harder, less force, harder for that force of the small airways, or harder for the force of the air entering the mouth to move past that, versus if more distally, for this extrathoracic obstruction, you can build up more pressure to get the air out. That's how I think of it. Fixed intra or extrathoracic obstruction, well, both loops. And that would be there's a blockage, both, or typically. So examples of this would be subglottic stenosis. But again, this is all large airways. So just wanted to present this as a caveat, but we're going to go now to an example. All right. So this is an example, and I want you to look at this because you can clearly see we're not reaching, this is a flow volume curve. We are not reaching peak expiratory at all. Okay, you can see that. And the flow forced vital capacity, though, you know, it's reduced. But you know, it's a kind of a game. Well, which one is reduced more, right? We look at the predicted, which is this is the predicted curve. This is the pre-bronchodilator, and this is a post-bronchodilator. So there's not a lot of change with the albuterol. And then we look at the numbers, right? FEV1 is very low. FVC is low, only 45% predicted. The ratio is low too. This would be normal, 77%, and they're at 53%. And just please note that this key, it says taken from Hyatt's Interpretation of Pulmonary Function textbook. The textbook only provides a flow volume curve image. And just a reminder that FEV1 cannot be calculated from a flow volume curve. Only the FVC can be calculated from a flow volume curve. So what I would write for my interpretation of this is obstructive pattern. We look at the numbers, you know, for post-bronchodilator. You know, the number, even though it doesn't show up too much here, on looking on the image, you know, it does increase. So I would say, you know, some bronchodilator responsiveness. You know, here we are given the lung volumes, which we are not when we're doing the compensation and pension exams. If we were not given the lung volumes with this low FVC, you would have to say, you know, obstructive pattern, restriction cannot be ruled out. You know, you could order a DLCO. This example does order a DLCO. This would be normal, and this is what is observed. So the DLCO is low. And, you know, again, a low DLCO, that could be restriction or emphysema, but emphysema would be favored here because there is some bronchodilator response. Hyperinflation is also in this example present, reflected by the total lung capacity It's much higher than what would be predicted. That indicates air trapping, this high total lung capacity. The residual volume is also very high too, indicating air trapping. So that's what leans towards emphysema here. Restrictive patterns, we think about the pulmonary fibrosis, asbestosis, sarcoidosis, neuromuscular disorders, drugs, amiodarone, but then also chest wall deformities as well. Pectus excavatum, ankylosing spondylitis, scoliosis. DLCO is, again, typically low and restrictive lung disease. Please note a caveat that congestive heart failure with bilateral pleural effusions can mimic pulmonary fibrosis. And this is just an example here about different restrictive lung conditions where the restriction is coming from, whether it's coming from the lung parenchyma, the pleural cavity because there's an effusion or a tumor, the chest wall with a chest wall deformity, or a muscle issue where the diaphragm is paralyzed or there's a neuromuscular disease. Again, in the restrictive lung disease, the peak expiratory flow may be reached, but the forced vital capacity is so much less than in the obstructive. Okay. This is a really good example I found in a textbook showing the restrictive flow volume loop pattern is compared with a very small balloon. It takes a very high pressure to fill up a small balloon, but the balloon never gets big. The air comes out very fast from a small balloon. Another analogy would be an anthill or a hat with a very steep flow due to the high elastic recoil, but the volume is low, just like a small balloon. So this is another way of thinking about the restrictive pattern. This is a case here, and again, this is from the textbook here, and it only provides us with a flow volume curve, expiratory flow volume curve. But in this one, this is a predicted, the dashed line, and then this is the spirometry value against the predicted. You can see that there is a peak expiratory that is reduced for sure, but the forced vital capacity is only 1.1 volume. I mean, really a little bit above 1 liter for the volume versus the predicted should be 6. And here it is. The predicted forced vital capacity is 6, and that's just taken off this curve, right? You can't get an FEV1 again off of an expiratory flow volume curve. You can only get the FVC off of it. So yeah, this patient has a FVC only just above 1 liter. That's only 19% of what would be predicted for their age, weight, height. Okay. FEV1, it's not great either for this person, right? And again, FEV1 cannot be calculated from a expiratory flow volume curve, but it's very low. Okay, so we think to ourselves, what do? We have low FEV1, we have a lower FVC. So I'm thinking, okay, either obstructive and restrictive, or, but which one is dominating? The FEV1 to FVC is normal because these are both reduced, but the FVC is reduced more than the FEV1. This would be predicted for FEV1 to FVC, and this is what's observed. Okay. But then we look at the total lung capacity, which again, we don't get normally for our exams. Look at how low this total lung capacity was compared to our obstructive emphysema case that we initially did. This total lung capacity is so low, only 28% predicted. That really indicates restriction. We look at the DLCO. This would be normal, and their result is only 9. 26% predicted. Again, restriction. So this is definitely restriction. You would expect with this patient, the oxygen saturation, if it's normal at rest, to decrease with exertion. But restriction is a predominant. You could say there's also maybe an obstructive component, but restriction, especially with the low DLCO. So again, just highlighting the importance of DLCO in this one. This is another example of restriction, not as dramatic as the last one, right? So this is a predictive, the dashed line, the solid line is the actual result. And you'll see that the peak expiratory flow is reached very similar between the predicted and the actual results, but the forced vital capacity is low. It's only about 1.5. Normal would be predicted for this person. Normal would be 2 maybe 6, 7. Here we go. So yep, that's exactly what the numbers are saying on the recording. So FVC is only 57% predicted. FEV1 though, we're doing better. We're at 62% predicted. Again, this is just peak expiratory flow. You can't calculate FEV1 off of a flow volume curve. FEV1 to FVC is 86% predicted. Again, that's because the FEV1 is higher than the FVC. Look at the total lung capacity. We're at 77% predicted, so it's reduced. And we look at the DLCO, it's a little bit low. Not as dramatic as the other example we just did, but. So DLCO is relatively normal. Total lung capacity is reduced, indicating restriction. FEVC is more reduced than the FEV1. So this DLCO is just not super low. You know, it's almost 80% predicted, which, you know, that's really the threshold for normal is 80. If it's below 80% predicted, you know, we really consider it more abnormal. So it's really close to normal. We look at that BMI though. So with this one, we're really suspecting that maybe there's the extrathoracic obstruction from obesity, the high BMI, extrapulmonary obstruction. This is an interesting case that I found in the textbook where arm span was used instead of height. And you'll see here, like what we've been seeing with restrictive lung disease, a low FEC, lung volume here is about 2.3, and then the predicted would be 6.3. Peak expiratory flow is low. You know, we have a low FEC and FEV1. The ratio is preserved. But yeah, the arm span height is used here. So arm span height is used when there is scoliosis, because scoliosis causes areas of compressed lung. So I'm going to show you on, so this would be a restrictive lung disease. You know, the DLCO is only 50% of what would be predicted. Total lung capacity is low, but it's restrictive because of the scoliosis. If we were to just put the height of this individual, it changes dramatically how it looks, this curve. You know, we go from here, there's a much lower peak expiratory flow. Same forced vital capacity though, but the peak expiratory flow changes. So it's really important, patients with scoliosis, to use the arm span as instead of the actual height. The arm span can also be used on patients who cannot stand up straight or who are in a wheelchair. So this will be our last example we're going through today, highlighting the difference between obstructive and restrictive lung disease. So I hope this helps with your interpretation when you are going through your own results that you get from these spirometry. Thank you.